The acute coronary syndrome, or ACS spectrum, consists of unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction. The key difference between ST elevation MI and non-ST elevation MI and unstable angina is that ST elevation MI results from complete coronary occlusion causing ST elevation and requiring immediate reperfusion, whereas non-ST elevation MI and unstable angina are caused by partial coronary occlusion. Aspirin is the single most critical first-line therapy in acute coronary syndrome and should be administered immediately at a dose of 325 milligrams in chewed form, even before obtaining an ECG if ACS is suspected. Chewing the tablet rather than swallowing it whole achieves faster absorption and more rapid antiplatelet effect. This simple intervention reduces mortality by approximately 25%, making it the most important medication in the initial management of ACS. The key principle is to never delay aspirin administration. It should be given at the first suspicion of ACS, as every minute counts in limiting myocardial damage and preventing thrombus propagation. An electrocardiogram must be obtained within 10 minutes of presentation for any patient with suspected acute coronary syndrome. The primary purpose of this strict time requirement is to rapidly identify ST elevation myocardial infarction, STEMI, which represents complete coronary artery occlusion requiring immediate reperfusion therapy. Early ECG acquisition allows for prompt activation of the cardiac catheterization laboratory and initiation of time-sensitive interventions, as delays in reperfusion directly correlate with increased infarct size and worse patient outcomes. This 10-minute door-to ECG time is a critical quality metric in emergency departments and reflects the time is muscle principle that drives all STEMI management decisions. Aspirin exerts its antiplatelet effects through irreversible inhibition of the cyclooxygenase 1 (COX1) enzyme in platelets. By blocking COX1, aspirin prevents the synthesis of thromboxane A2, a potent mediator of platelet activation and aggregation. This irreversible inhibition is particularly important because platelets lack a nucleus and cannot synthesize new COX1 enzymes, meaning the antiplatelet effect lasts for the entire lifespan of the platelet, approximately 7 to 10 days. The resulting decrease in platelet aggregation significantly reduces coronary thrombus formation and propagation in acute coronary syndrome, which translates directly into reduced mortality. The cornerstone of why aspirin remains the most important first-line therapy in ACS management. Aspirin has remarkably few absolute contraindications in the setting of acute coronary syndrome, reflecting its critical importance as life-saving therapy. The only true contraindications are a documented true aspirin allergy, which is extremely rare and distinct from aspirin intolerance or sensitivity, and active life-threatening bleeding. Importantly, the threshold for withholding aspirin should be extraordinarily high, as the mortality benefit in ACS far outweighs most potential risks. Nitroglycerin should not be administered to this patient because the combination of inferior myocardial infarction and hypotension with clear lung fields is highly suggestive of right ventricular infarction. The right ventricle is critically preload dependent, meaning it requires adequate venous return to maintain cardiac output. Nitroglycerin causes venodilation and reduces preload, which would severely compromise right ventricular filling and worsen the hypotension, potentially leading to cardiovascular collapse. When inferior MI/ST elevations in leads 2, 3, and a VF presents with hypotension, right ventricular involvement must always be suspected and can be confirmed by obtaining right-sided ECG leads, specifically looking for ST elevation in V3R and V4R. Nitroglycerin works through three complementary mechanisms that improve the supply-demand mismatch in acute coronary syndrome. It decreases preload through venodilation, decreases afterload through arterial dilation, and causes direct coronary artery vasodilation. These effects work synergistically to reduce myocardial oxygen demand by decreasing the workload on the heart through reduced preload and afterload, while simultaneously increasing oxygen supply through coronary vasodilation that improves blood flow to ischemic myocardium. The preferred initial route of administration is sublingual, given as zero point 0.4 milligrams tablets that can be repeated every 5 minutes for up to 3 doses to relieve acute ischemic chest pain. If pain persists after 3 sublingual doses, or if ongoing ischemia requires continuous therapy, an intravenous nitroglycerin drip should be considered for more sustained effect and easier titration based on blood pressure response and symptom control. Supplemental oxygen in acute coronary syndrome should only be administered when there is a clear indication, specifically when oxygen saturation falls below 90%, or when the patient is experiencing respiratory distress. The target oxygen saturation range is 90 to 95%, not the higher levels that were once pursued. This represents a significant shift from historical practice, as routine oxygen administration to all ACS patients is no longer recommended and is not part of modern ACS management protocols. Morphine has evolved from a routine component of ACS management to a medication that should be used sparingly and only when clearly necessary. Its current indication is limited to severe refractory chest pain that persists despite adequate nitroglycerin administration, administered at a dose of 2 to 4 milligrams intravenously and repeated every 5 to 15 minutes as needed. However, morphine carries significant cautions that have downgraded its role in modern practice. It may mask ongoing ischemic symptoms, making clinical assessment more difficult, and some studies have associated its use with worse patient outcomes, possibly through effects on platelet function and vasodilation that could reduce coronary perfusion pressure. As a result, morphine is no longer considered first-line therapy for pain management in ACS, and clinicians should exhaust other pain relief strategies, particularly optimizing nitroglycerin dosing, before resorting to opioid analgesia, using it judiciously when pain control is essential for patient comfort and reducing sympathetic stress. Dual antiplatelet therapy, DAPT, is the cornerstone of pharmacologic management in acute coronary syndrome and consists of aspirin combined with a P2Y12 inhibitor, both given together to achieve more complete platelet inhibition than either agent alone. This combination works by targeting two distinct pathways of platelet activation. Aspirin irreversibly blocks the cyclooxygenase pathway and thromboxane A2 production, while P2Y12 inhibitors block the adenosine diphosphate ADP receptor pathway that promotes platelet aggregation. By simultaneously inhibiting these two independent mechanisms of platelet activation, DAP provides synergistic antiplatelet effects that are far more effective at preventing recurrent thrombotic events than single-agent therapy. The standard duration of DAPT following an ACS event is typically 12 months, after which the P2Y12 inhibitor may be discontinued while aspirin is continued indefinitely, balancing the ongoing benefits of dual therapy against the cumulative bleeding risk over time. There are three P2Y12 inhibitor options available for dual antiplatelet therapy in acute coronary syndrome, each with distinct pharmacologic profiles that influence clinical decision-making. Clopidogrel, Plavix, is the oldest and weakest of the three, with slower onset of action and less potent platelet inhibition. Ticagrelor, Brilinta, offers intermediate potency with the unique characteristic of being reversibly binding, allowing for recovery of platelet function if the drug is stopped. Prasugrel, Effient, is the strongest and fastest-acting agent with irreversible platelet inhibition, providing the most robust antiplatelet effect. For STEMI patients proceeding to primary percutaneous coronary intervention, ticagrelor or prasugrel are strongly preferred over clopidogrel because their faster onset and more potent platelet inhibition better prevent acute stent thrombosis during the procedure and reduce recurrent ischemic events. In contrast, for NSTEMI, patients being managed medically or conservatively, either clopidogrel or ticagrelor are acceptable choices, as the urgent need for maximal platelet inhibition is less critical in the absence of immediate intervention. Prasugrel is absolutely contraindicated in this patient due to his history of stroke 1 year ago, which represents the most important contraindication to remember. Prior stroke or transient ischemic attack is an absolute contraindication to prasugrel, because the medication significantly increases the risk of intracranial bleeding, and patients with prior cerebrovascular events are at particularly high risk for recurrent hemorrhagic complications. Additionally, this patient has a relative contraindication based on his age of 78 years, as prasugrel use in patients over 75 years old has been associated with increased bleeding risk that may outweigh the ischemic benefits, though age alone is not an absolute contraindication. Other important contraindications to prasugrel include body weight less than 60 kilograms, higher drug levels relative to body mass increased bleeding risk, and active bleeding. For this patient proceeding to primary PCI for STEMI, ticagrelor would be the appropriate alternative, P2Y12 inhibitor, as it provides similarly potent and rapid platelet inhibition without the same stroke-related contraindication that makes prasugrel unsuitable. Ticagrelor has a unique and clinically important drug interaction with high-dose aspirin that significantly reduces its antiplatelet efficacy, making dose adjustment essential for optimal therapy. When ticagrelor is combined with aspirin doses exceeding 100 milligrams daily, the antiplatelet effectiveness of ticagrelor is paradoxically diminished through incompletely understood mechanisms, potentially compromising patient outcomes. Therefore, while the initial loading dose of aspirin in acute coronary syndrome is 325 milligrams, the maintenance aspirin dose must be reduced to 81 milligrams daily when used in combination with ticagrelor to preserve its full antiplatelet effect. Beyond this critical drug interaction, clinicians should be aware that ticagrelor is contraindicated in patients with severe liver disease due to hepatic metabolism and potential accumulation. Additionally, ticagrelor commonly causes dyspnea as a side effect in up to 15% of patients. While this shortness of breath is bothersome and may affect medication adherence, it is not dangerous and does not indicate underlying pulmonary pathology, distinguishing it from dyspnea related to heart failure or other serious conditions.